So thank you, Dr. Magdad, for that very insightful talk. So next, we have a talk by Mr. Taimur Khan Jhagra. He was the Provincial Minister of Khyber Pakhtunkhwa for Finance and Health and a member of the Provincial Assembly of Khyber Pakhtunkhwa. Mr. Jhagra is a mechanical engineer with an MBA from London Business School. Mr. Jhagra's key area of expertise includes strategy, change management, and large-scale transformations across education, health, and economics development. He will be talking about the initiatives taken in Khyber Pakhtunkhwa to improve health outcomes. This is a good time to talk about it given the findings of the Pakistan Burden of Disease study, as kindly pointed out by Dr. Magdad, which showed the lower life expectancy gains in Khyber Pakhtunkhwa and Balochistan over the last 3 decades up to 2019. If you could please come to the stage.
Good evening, everyone. It's a pleasure to be back. It's a pleasure to be back. I was here about a year and a half ago talking about our universal health insurance program. I'm really happy to follow up on Dr. Mogdad because I think the two presentations gel together. And I'm going to ask for about 5 or so extra minutes. I think the story here will lead to a lot of what I think Dr. Mogdad rightly said we have to do. Data is important, and in academic institutions, people get very excited about data. But I think what really ends up mattering is whether you can use data for decisions to make a difference, or indeed whether you can actually back up the decisions that you've made by data so that you can further the reform journey that you've been on. And I'll be trying to do a little bit of both. What we've done in the health ecosystem in Khyber Pakhtunkhwa in the last 10 years isn't easily explainable in 20 minutes or so. But I just want to give you a flavor of where I think our health system has to go to not end up having outcomes such that we look at a graph for infant mortality in Bangladesh and say, why them and why not us? The answer is very clear. In no place, and in particular in healthcare, business as usual in terms of the way that we manage the system does not work, will not work, hasn't worked for 75 years. You have to be bold to change it, and you have to be patient for results. But I think if you do the right thing, the results are there. One of my favorite bureaucrats who has worked on health reform in Pakistan passes a statement that I really like. He told me once, sir, there is a difference between managing the health sector and managing the fisheries department. They're not equal, they're not the same, and it is true, right? It is just true. The problem in the public sector is that we have a one-size-fits-all approach for every sector. My friend Faisal's also here from Peshawar. It's very interesting. You want to hire a data scientist in the public sector, if he wants to have a pay beyond something like 3 lakhs, he probably needs to have 20 years of experience and 100 trainings on his CV, which means he needs to be something like 45 years old. Doesn't exist. So you get lots of these anomalies in government because we use this one-size-fits-all approach. And my 3 years as a health minister, so patently clear that our health system is such a complex one. Any health system is such a complex one. There's so many interdependencies within, from health education to the health governance system to outside, health financing, other systems of government, what the private sector gives you, etc., etc., etc. So, indeed, there's a difference between the health sector and managing fish. And that is indeed why you need to use data in a better way. Now, I'm going to take this problem a little bit top-down rather than bottom-up, right? How do we use data to manage a system, and how do we manage a system, and what place does data have in it? And so the outcomes, the outputs, the sort of priorities that I have are slightly bigger picture then some of what will have been discussed, and also frankly, I'm not a medical professional, so a lot of the terms that Zainab was talking about are a little bit like Greek to me. I speak a bit of French, so I won't say French. But 4 things. I think 4 key success factors if you actually want to marry data to action. At the large-scale public sector level. 1, we need to be able to devolve. We need to devolve decision-making. Our health system can't run if it is run centralized. And you know what? The way our health system is designed, it's designed to be run out of one office. If you look at all of our large tertiary hospitals, until the system was broken in KP, they were all run out of one health secretary's office. This is true of the power sector as well, which is why we have such a great time keeping the lights on in Pakistan. But you need to be able to devolve governance to be able to get health outcomes right. The second thing, financial empowerment. Financial empowerment not just to districts and regions and hospitals, down to the individual BHU, the individual primary care facility, and I think you see results. The third thing, accountability. By having a one-size-fits-all approach, we have a template where in our health system, you have not just 200 hospitals and 1,000 facilities in a province being managed through one office. You also have 80,000 staff that are managed through one office on paper, and hence no accountability. So you need to change the systems. A doctor is not a DMG civil servant, should not be treated like one, and you need to make that break. And last, I think the philosophy, and many people get this wrong, in many sectors, but certainly in health, government needs to be doing health to get outcomes and to fulfill its obligations. So it's a service provider. It's not an employer as its primary role in healthcare. Its job is not to ensure that doctors get pensions. Its job is to ensure that patients get treatment. Those 4 critical elements drove our reform, and I think you'll see some of the results, some of the innovations, and I think the actual impact on outcomes you'll see over the next 2, 3, 4 years, provided we continue the journey we've started on. Now remember the context this is happening in, because there's a lot of, there's 2 things. One, as already pointed out, data can be quite creative in Pakistan. And what do I mean? In the early days of COVID, I insisted with the administration that we report every death accurately. I felt, as someone who has managed large systems, that in order to be able to get to the right conclusions, we needed to know what's happening. Very interesting that in 2 to 3 weeks, as our numbering, our reporting of deaths was indeed accurate, I got words of wisdom from a very senior official in government to say, it was good to be honest, but it was also good to be pragmatic, because the numbers were hurting us. How can the numbers hurt us? You know, if people are dying, we need to know exactly what is happening where so that we can take action. Right. The problem was that it was clear that in other regions, data was not being reported in the same way, and it almost felt that in our culture, the competition was more important than the ability to save lives. And sometimes you have to be bold when you get into situations like that to be able to get to the right outcomes. The other thing, remember, and I didn't know about your lecture, but just to it just strikes me, it's very interesting. We talk of life expectancy. I think I've actually seen a lot of the independent surveys show the level of improvement in general in health outcomes in the last 10 years and in human development indicators in Khyber Pakhtunkhwa. So I was a little bit surprised to see the death data on 2021. But one thing certainly is true, right? If you look at the number of people lost in the war on terror and the impact that this has on society, one would have to figure out what it means in terms of death rates. But of the 80,000 or so people that we say we've lost in the war on terror, 77% in Khyber Pakhtunkhwa. Almost 8 in 10. I think this graph shows 71. There's another one where we calculated 77. Anyway, 7 in 10 or 8 in 10 in a province that holds 15% of your population. And the impact of that, not just on lives lost, but these events have happened at hospitals, these events have happened at police stations, these events place a huge strain on your health system, and you're constantly firefighting. And what we've tried to do in the last 4 or 5 years is to get away from that. So anyway, to quickly take you through 5 interventions, where I think indeed data will prove that there is a way to reform our health system. There's a long, long way to go. There's a long way to go. But I feel that in 5 areas where we've hit the right notes, and that is perhaps part of a blueprint for Pakistan. The first is what we do with our large hospitals. And I think, frankly, as far as our large hospitals are concerned, it is interesting to be talking here at AKU, because this is indeed the best hospital in Pakistan. But the principles that make AKU Hospital a good hospital is something that we tend to forget when we manage most of our large general hospitals in the public sector in Pakistan. And actually, if we just take a few basic principles over here and apply them to the way public sector hospitals work, you will start to see a difference. I call it breaking the Babu Raj, or how to ensure that not every hospital is run from the health secretary's office. But something that was done in our first term in Khyber Pakhtunkhwa was to give our large hospitals autonomy by being self-run, under the government, run by boards, with single-line budgets. I can tell you the bureaucracy hated it. I can tell you they still hate it. I can tell you they will continue to hate it until we change how the bureaucracy works. Why? Because they don't control the hospitals directly. Their sort of ability to act as VIPs in our health system reduces. And so they will almost challenge every part of it. Right? But over 7 years, I can show you the sort of difference it's made. And I can show you also where it actually made a huge difference to lives. So just a few pictures. This is KTH Hospital in Peshawar. I don't take the credit for the way this is being developed. It was done by the board. We devolve the way the hospital is run to them, and they do a good job. I also hate all of these things. They decided to build modular theaters. I believe they may have more than you have over here, right? But this hospital starts to work. And it's not like AKU Hospital where it's built for purpose and can take a fresh start. This is a 55-year-old organization that's being transformed on the fly. It's the first general hospital in Pakistan that's ISO certified in terms of its processes. This was done last year. More. This is their dental college, again done by the board. Again, means it can bypass a lot of the red tape that they have. This is the new cardiology institute that we have. There's none in Peshawar. There's one that now rivals NIVCD that has the best staff, some from AKU, some from Shaukat Khanum, some from abroad, giving top-notch cardiovascular treatment in Peshawar. Why does it work? It's run by the board. This is Lady Reading Hospital, the oldest hospital in the province, built 1926, 2,000 beds. In COVID, it served 500 patients a day at peak. I think that was more than any other hospital in Pakistan by a factor of 2. Why could they do it? because they had the autonomy to take decisions and they were adapting wards on the fly. There were 4 weeks in KP where we were basically running at 100% bed capacity, but we didn't turn out a patient. Why? Because this hospital was able to continue to add capacity, and take the marginal load. Why? Because the governance system improved. And this old hospital now has a 500-bed unit that is second to none in the country. In the recent police lines blast in Peshawar, 200 people treated in one hospital, not a single complaint. Hayatabad Medical Complex, another one. The difference in terms of when these hospitals used to be run previously through the traditional governance system to now is best served through our latest medical teaching institution, the one in Sawabi, just 3 figures. And I'm sorry, I understand simpler data, so I'm just going to tell you what I understand simply, which is how people vote, where they vote to go. It, for me, represents the amount of trust they have in our health system. And I feel that if they go there, and they go there because the entity is delivering for them, and over time and at scale, that will start to deliver better health outcomes. So this MTI was created last year. There's an existing hospital there which was quasi-dysfunctional. In a year, they've doubled bed capacity. They have doubled OPD numbers. They have increased inpatient coverage by almost a factor of 3. And they have increased emergency numbers almost by a factor of 3. Why? Because suddenly the hospital is not being controlled by Peshawar, but by a group of 7 people, including very capable individuals, in this case someone who used to head CMH in Rawalpindi, a retired general, and they manage the hospital for the government. So what I can tell you is certainly, and I hope you guys can go and see this, as far as our general hospitals are concerned, again, lots of improvement areas, but I am willing to bet that if someone does a comparative study compared to Karachi or Lahore, where you have one MS appointed by a minister or a secretary, funding that is controlled by finance, that our hospitals will be delivering much better results. This is an open challenge. They managed to take COVID, 5 waves, as I said, not turn away a single patient. And remember, if I were in Karachi and I had COVID, I would be going to AKU. We have 2 or 3 excellent private sector hospitals in Peshawar because the private sector finds its space in healthcare. But 90% of our patient load went to our large tertiary hospitals. They were the hospitals of choice. So I think that shows you, along the 4 dimensions that I said, devolution of governance, giving financial empowerment, in these large complex tertiary hospitals, they work. In COVID, it allowed us to increase capacity by 6x. We started with some ridiculously small number of ventilators in the system that we didn't even know worked or not. But because we could take decisions on the fly and quickly, we actually went to something like 1,400 HDU beds, 350 ICU beds, and oxygen capacity that we were managing. We had no centralized oxygen systems. And standard procurement systems would have taken forever to install them in. The hospitals did it quicker than the government could because we had devolved governance to them. And so I think it's interesting. The reason I spend a little bit of time on these medical teaching institutions is that today, in this small interim period of government, there's a question whether these board-run hospitals work and whether they should be returned to the department. Ridiculous. And perhaps the biggest price that we pay in Pakistan is not for initiating the right sort of reform, but for keeping on reversing it. We go round and round in circles. That's not going to take us forward, right? The difference that has been made in these 10 hospitals, which collectively are probably something like 8,000 to 10,000 beds. We are the top 4 are about 1,500 beds each, and the rest are about 500 to 600 beds. So 8 to 10,000 beds actually serve the entire province for a lot of its secondary and tertiary care needs, because we know that traditionally the rest of our system has been weak. So this is one major intervention. But what is true is, as a health manager, where one differs from, say, an academic is, I don't have the luxury of time to do small experiments. I have the luxury perhaps to get things wrong. But where I have to serve 40 million people, I have to take relatively big decisions because people's lives depend on it every day, and otherwise I'm in a constant firefighting mode. So if there's one intervention that I think should be at the heart of our health reform, is health financing. And I talked about this before, I'm going to be briefer about it right now. I am proudest of the fact that we're the first province that delivers universal insurance in critical care, emergency care, and inpatient admissions for the large part to everyone. And we do it with a lot of thought. Adil is currently evaluating the whole program. Maybe we talk more about it in the Q&A. But this makes a difference. See, when we go from covering 25% of the population to 100% of the population, so a 4x increase in coverage, and the big thing that it does for me in the short term is it creates simplicity. It takes a transaction out of exclusion, out of the decision of who to give health insurance to. Utilization has increased not 4x, 20x. Why? Because when you actually think of it, the entire middle class, no better time to think of it than right now, when the dollar is falling by 20 rupees on one day, then going back 8 rupees the other day, the entire middle class outside of the top 1 or 2% cannot cover or cannot easily absorb the shock of critical health care when they need it. Heart bypass, liver transplant, even delivery. And this makes a huge difference. Makes a huge difference. But more importantly, and I think this is something where we've only scratched the surface, this gives us such a goldmine of data that I think it is the biggest tool for policymakers, because we now have 2 million people who have used it literally in the last 2 years. 1.3 million people who will use it this year. Every year, 10% of families are using health insurance. Of course, it's going to evolve, but as well as being a tool to save lives, as well as being a social safety net, it is perhaps our biggest potential policy-making tool that we have. We take simple decisions where to invest, what hospitals to start financing. But of course, when you look at things like the burden of disease, what it is used for, what it is not used for, in which district it is used, we have every patient data, and no one's fudging this, because the insurance company is looking at it for the right reasons. So you know exactly what's happening to every patient everywhere. The system works. Again, data is important, because what you hear anecdotally is, I've actually even heard that I put half the money in my pocket. But 97% of people are satisfied. 96% of respondents, of course, say that it has a significant impact on out-of-pocket expenditure. The other 4% are the elite. And it gives everyone accessibility. This is third-party surveys. This is third-party audits. But more importantly than this, data and numbers. When we make the argument that why are we spending on the private sector, remember that by including 200 hospitals in the net, I'm actually getting the benefit of 100 billion rupees of capital expenditure that I haven't spent out of pocket. Also remember that actually, in terms of policy-making perspective, it's $2.5 per head per year. And by the way the rupee is falling, it may be getting cheaper every day. It's 2% of our budget. it's 15%. We decided to top it up as additionality in health spend. It's 15% health spend, and where our health spend is about half of what it should be versus comparative countries, I think it's the best investment of a 15% top up that there could be. And interestingly, since we went to universal insurance, the utilization through public sector hospitals has increased by a factor of 3. It's not reduced, it's increased by a factor of 3, from 11% to 33%, which also tells you, the first section of my presentation, that our tertiary hospitals must be working, because people are going and using it there in greater and greater numbers, and it then has a circular beneficial effect because it's giving them additional finances to be able to become centers of excellence. So just to go on, and I'm probably taking 5 minutes more than I should have, but I'll try and wrap up in 5. 3 more interventions, just to quickly see, because we can't ignore the rest of the system. Our biggest challenge across the country is everyone can't come to Aga Khan, everyone can't go to the hospitals in Peshawar, and the periphery doesn't work. Our secondary care system is dysfunctional, and I think if you look at something like the long tail of 70% of hospitals across the country, you'll find inpatient utilization of less than 5%, which means that you have something like 100,000 beds that you've invested in and made that don't get used. The answer, my 4th point, outsource them. Remember, you're not a pension provider, you're a health service provider. The private sector has the capacity, they can run them for you. We outsourced 19 hospitals. Where? In ex-Fata, in the remotest part of the province, where more than half of these 77% of deaths have occurred. Before outsourcing, look at the number of specialists in these hospitals, 0. Look at the number of doctors in these hospitals, 10. Afterwards, 212, because the market works. I've seen gynecologists from Karachi work in South Waziristan. And look at the numbers. OPD goes up by a factor of more than 2. Inpatient didn't exist. You now have 100 patients a day. Accident emergency by a factor of 16. These were ghost hospitals that have changed. Similar numbers for the next set of 11 that were outsourced, from almost no staff to 339 staff. And by the way, what's interesting with the private sector is, because of recent fears of accountability, these hospitals haven't been paid for the last 3-4 months. They're still working. Imagine public sector officials working without a salary for 5 or 6 months. And just to show you the before and after, this I do take more credit for, although we as a nation will somehow take every effort to discredit initiatives like this. Before and after, this is in Khyber district. This is in Momand. I bet some people wish there were hospitals in Karachi outside of Aga Khan like this. This is in Aurangzai. This is the first hospital that I saw and I felt it's amazing. It's our best district headquarter hospital. It's outsourced. This is in South Waziristan. This is where I saw the gynecologist from Karachi who flies in, flies out every month because no one from Peshawar will go. South Waziristan, you get the picture. So is the answer just health insurance and outsourcing hospitals? No. We need to get our existing hospitals to work as well. And what we tried to do in a simpler way was to implement the same philosophy of getting these hospitals more self-governed, effectively by financially empowering them, giving them marginally greater budgets, and along with that, trying to, in all of the more highly utilized hospitals, putting in our best people and letting them stay there, and de facto giving them the power to hold their staff accountable, because the rules don't allow them. So that was our secondary care revamp program. The money spent wasn't great, but again, look at the numbers, because we said today would be about data. This has happened in the last year and a half. Vaccination rates go up, bed occupancy rates go up, OPD rates go up and stay up, and bed occupancy rates go up by almost a third. Again, why? Because by empowering hospitals, people can start to invest in themselves. And when you start to invest in yourselves, you change the relationship between citizenry and the health system. By giving them the ability not just to rely on government staff, they can put staff from the market there, and these can start to feel like places that you and I would go to. They can start to invest in systems that allow them to give a better patient experience. And we did this not just in our secondary hospitals. We started to do this in our BHUs. And this is perhaps the only part of the health system that is slightly simpler, because everything else is so complex in terms of its interdependencies to get right. Every BHU in Pakhtunkhwa since about a year and a half has a primary healthcare committee, and it gets a small amount of funding, 5 lakh rupees or so, to be able to invest in itself. In 1 year, 500 plus facilities revamped, and here's the difference. And again, this is not Peshawar. This is somewhere in remote areas of Kohat. 5 lakh rupees. What I'm told is if you do this through standard government setups, it would take 50 lakh rupees to do the same work. Once the doctor has a better environment to work in, he's more motivated and patients start to come. Another one, Kohat, Kohat, Kohat. This is Karak, an even more remote district. You'll see different colors. I was told we should have standardization. I said, no, we just need to give people the money to go and improve their own facilities, and patients should vote. And what did patients do? These were some of the worst facilities in Peshawar. So we say that these facilities are better, but what do patients say? The average OPD or footfall in BHUs increases by a third in less than a year. Medicine availability increases. Infrastructure increases, and cleanliness increases massively. You can still see there's a massive amount of way to go. But this starts to give you results. That's not just about patients visiting basic clinics. This will have an impact on your vaccination rates. This will have an impact on routine immunization. This will have an impact on polio and family planning. This will have an impact on that basic unit. We've invested all of this. Every union council in Pakistan has a primary care facility. But traditionally they've had a cow or a dog or a goat in them. And that's changing because, again, we use that rule, empower them, let them manage their own facilities. For me, 3 things on top of that, about to wind up. If you've got to do reform like this, you've got to be hands-on. In COVID, while dealing with the tertiary hospital after one incident in Peshawar, the next 2 years, 9 a.m., I was talking to all the 10 major hospitals, because not only did we have to manage things like supply deficiencies, but also if anyone had an oxygen potential shortage. Because for a year when there was a global shortage, we had to do just-in-time management, and this was not a system that was used to dealing with emergencies in this way. But it worked. I mean, 2 hours of 9 a.m. 2 hours of 9 a.m. Zoom meetings for 2 years is a lot of time, but it worked. Sometimes you need to ignore the textbook. Why do I say that? Because I've never heard that the first intervention you should do in healthcare is health insurance or health financing. But personally, for developing systems with some capacity, if I were to invest in one place, it's that, because you can bridge the gaps quickly. Getting the public sector right is a huge task. And third, ignore the fear of accountability. People are going to point fingers at you, but you have to do this as a leader, because if the bar on reform is going to be limited by the fact that every time you do anything innovative, the vested interests in the system will point fingers back, we're not going to get anywhere. And some people have to break that cycle. Interestingly, to end on a funny note, the reason I know, for example, that this is the right journey goes back to the MTIs where I started with. I saw this as a headline in Dawn a few days ago, the Peshawar version. And I think it was meant to be critical of the reform. In the end of PTI government brings sigh of relief for civil servants in medical teaching institutions. It actually means we were right. And inshallah, the next time, we have to make sure that they're hoping for greater sighs of relief, because we're not doing it for the people we pay. We're doing it for the patients so that we can show Bangladesh that Pakistan can do better. Thank you very much.